Spotlighting Hawaii's leaders.
We want to bring in Governor David E.
Good morning, Mr. Mayor.
Lieutenant Governor, good morning. Thanks so much for joining us. Mayor Derek Kawakami.
Thank you so much, Senator, for being here.
Spotlighting the issues.
Where is the virus right now in our community?
How much is this overall going to cost the state?
How are you responding to the community's concerns? Talk about the level of citations that you guys are writing.
Spotlight Hawaii with Yunji Denise and Ryan Kalei Suji on the digital platforms of the Honolulu Star-Advertiser.
This episode of Spotlight Hawaii is brought to you by Long's Drugs.
It helps if I unmute the mic, doesn't it? Good morning, I'm Yunji Denise. Thank you so much for joining us here on Spotlight Hawaii. Ryan is off today for the Good Friday holiday, but we are still soldiering on. We have some very important information to share with you today. We are so lucky to be joined by Dr. Tim Brown, a frequent guest on our program of the East-West Center. Of course, he is a senior fellow in the research program there and an infectious disease expert. Dr. Brown, thanks for being here. And Dr. Brown seems to be muted. Let's see if you could try to talk there.
Can you hear me?
Oh, there we go. Okay.
Okay.
Okay, a little bit of a shaky start, but we are off to the races now. We've got a lot of slides to share with our viewers this morning. We had news this week, Dr. Brown, of the mayor contracting COVID-19. By all accounts, he is doing well, but we do see the positivity rate overall going up. I know anecdotally, I've been hearing of a lot more families who are experiencing positivity in their own households. Tell us a little bit about how Hawaii is doing from your purview.
I think, part of the challenge I think we've had since we lifted the mask mandate at the end of March is that it's really been a kind of out of sight, out of mind sort of experience here in Hawaii. The Department of Health is really only coming out with numbers once a week, and even those are not getting publicized too much in the media. Wastewater surveillance is coming, but not until the summer. So we're not getting important information from that source about what's actually happening with COVID within the community. And the current CD4 community levels that are being used would not call for action until we were already very far into a serious epidemic. So I think, people have kind of forgotten about COVID. And they're acting like living with COVID means acting like COVID is not out there, whereas it really needs to mean that we need to adapt and adjust to really deal with the situation. So I think that, fundamentally what's happening right now is that people have kind of forgotten about COVID. But the reality is it is still spreading in the community, but it's spreading invisibly because people are not really getting access to the information and the data about what's actually happening in the community as a whole. So I think that that's what's going on right now.
Let's look at some of the slides that you shared with me that I want to share with our audience. This first one is showing our 7-day case average. When you look at that curve, it looks pretty good. Tell us about what we see here.
Okay, this is in fact the 7-day average. Basically, when you do get the weekly data from DOH, you can actually translate that back into the daily averages, which they do actually put on their website. It looks like we've seen a slight increase from when the mask mandate was lifted. Mask mandate got lifted around end of March, and we've seen a slight increase. Now, the problem is the cases appear to be growing gradually, and they're currently at 164 per day, which is still much, much higher than what we would have liked in the past. I mean, we locked down the state on numbers like that in the past, although we don't expect to do that now. But the problem is the cases are increasingly difficult to interpret, and that's because testing sites are vanishing very quickly. A lot of the larger testing sites have been completely shut down at this point. Where people are using home testing, that's not captured in the system at all. So people testing positive with a home test kit do not get reported. People are less likely to test now because employers have generally dropped their testing requirements for coming into work. And also because people perceive this as a lower risk situation right now, so they're less likely to test. As a consequence, we've seen the number of tests drop from about 8,000 per day at the end of March, or rather in early March, to less than about 3,000 a day right now. So there's been a major drop in testing. And of course, that translates into a drop in the number of cases as well.
So if that's the case, what do you think the true positivity rate is? If we're not testing, we're not finding. So what do you think the actual positivity rate is?
Well, let me come to positivity rate in a second. Let's go to the next slide, and let's talk about what what cases are missing right now. This is a slide basically from the United Kingdom, and what it's showing, the red here is a cross-sectional survey that they do. They actually test 10,000 people a week. So they actually know the level of COVID in the community. And this is, the red basically shows what that testing is showing, which at this point is showing, about 1.6 million, almost 1.6 million people infected. The blue here is the testing data, basically the cases reported. And you can see up until, basically this was the initial Omicron wave in the UK. Up until the peak of that wave, it was doing a pretty good job of tracking what the community data was showing. But after that, their testing system started to fall apart. They basically ran into capacity issues. They basically discontinued free home testing, which was reported in the UK. It's not reported here, but was reported there. And as a result, the number of tests dropped very rapidly, but the COVID was actually remaining high in the community here. And now we see that, yes, the number in the test has started to come up, but it's only about a third of the actual situation in the community. So the cases are not really capturing what's going on with the epidemic in the population as a whole. And that same situation really applies here in the United States, because we have discontinued so many of the testing sites. People are not testing as frequently anymore. And so the cases are not really reflecting what the situation is in the community.
So when you look at the testing, and let's go back to our own situation here, when we see this graph, what do you think this graph actually looks at? Would it be closer to what we just saw in that last slide?
Okay, this I think is the testing, the percentage testing positive in those who do test. And so even as the number of tests go down, if the percentage testing positive goes up, that's an indication that the overall level in the community is increasing. And so this shows you that, this is for Oahu, basically what we've seen is we've gone from about 2.5% in mid-March. We are now at about 5.6%. So we are seeing a very steady climb occurring in the positivity rate in those who are tested. Now, the number of testing has decreased very substantially over that time, and that's why the case curve looks flatter. But I'd say the positivity curve is the better thing to track right now, because it's giving us a better indication of what's happening within the.
You know, there are folks who say, well, COVID's relatively mild these days. People get over it relatively quickly. That, our leaders have said that they look at hospitalizations, not case count, as the indicator. How do you respond to that?
I would respond to that by saying that hospitalizations occur too late to guide public health. Public health needs to be about preventing the transmission of this virus through the community, even if it, in many cases, only produces mild symptoms. The reality is, for some people, it is still deadly. We've had about 350 people die in Hawaii during the Omicron wave. In the United States, about 300,000 people have died over that same period of time. So we are talking about something that is still killing a lot of people. And mostly, yes, agreed, it is the elderly, it is those who are immunocompromised, those who have other problems. But as a society, we cannot just ignore those people and act like they're not there. And I think that, the real problem we've got right now is our guidance is all formulated about when the hospitals fill up. It's not about actually preventing people from getting infected in the first place. And the other problem with that is it also neglects, there are things like long COVID, which is real. Long COVID basically can result in fatigue, heart problems, heart palpitations, weakness, inability to even walk up a flight of stairs. And this is prolonged over, we know some people have long COVID for at least 2 years at this point. And
yeah, that is
in the
terrifying.
UK, they're estimating that 2 to 3% of the entire population has long COVID at this point. And so it is a serious problem, and it can result even from a mild infection. It does not require that you get a severe infection or get hospitalized. So again, by not doing prevention, we're ignoring those impacts in our society as well, which would be long-term impacts that will have healthcare implications going forward.
I want to ask you, sticking with the UK, what we can learn about what's happening in other countries. We often look to the West because it seems that they are usually a month or two ahead of us. So let's go to this next slide. And it's a little busy, so viewers, bear with us. But Dr. Brown, tell us what we're seeing here.
Okay, let's start by focusing on Denmark. That was the place where BA2 really went to town first. Okay, you can see in this slide, the green is the Delta wave, which was comparatively small. Then BA1, which is the original Omicron, came along. That's the kind of orangish color. And that grew to much higher levels than the Delta wave because it was so much more contagious than Delta. And then BA2 came along, which was more contagious than BA1, and it basically forced out the BA1. And so you can see in Denmark, it rose to extremely high levels before beginning a very, very rapid drop. Okay. In other countries in Europe, let's look, for example, at Switzerland, it played out with a somewhat different pattern. The Delta wave held for a while, then they had their BA1 wave, but their BA2 wave started later than it did in the Netherlands. And so basically it came up almost as a separate surge, whereas in Denmark, it looked like it was one giant surge combining all the waves. So I think that it's important to recognize that this is playing out differently in every country. And that's a very, very important thing to understand.
Let's look at us now in relation to these graphs. When you look at this particular graphic compared to other countries, we look pretty good.
We do. And, Spain looks somewhat similar to us, relatively low BA2 wave at this point. But let's look at France, which I think is basically where we might be a month out or so. What happened in France, they had a big BA1 wave, but they kept precautions in place. They were quite cautious. They've kept their vaccine requirements for entry into places. They've done a lot of things in terms of keeping it safer. And so their BA2 wave was blunted initially, but now it's gaining power, and we see that it's starting to rise again. Now here in the US, our BA2 wave has been coming along fairly slowly, but it's also growing very rapidly throughout the country in terms of percentage of all cases in the US. And so I want to discuss that maybe in a little more depth. But before we do that, let's look at the hospitalizations in Europe. Because part of it is we are looking at hospitalizations. So France, which I said is maybe a month ahead of us, saw hospitalizations decline, but then they started to come up again. In the US, we've been fortunate because as the Omicron wave has come down, our hospitalizations have continued to decline, but they are now starting to rise in the northeast of the country. UK has seen the hospitalizations go back up with that very large BA2 wave that they had. And again, the National Health Service is under severe pressure right now in the United Kingdom, is basically being pushed right to the brink. Denmark, which got past its wave, is now seeing hospitalizations decline. Spain, they're just starting to climb right now. So again, hospitalizations lag what goes on with the cases. And that's an important thing to keep in mind. So when we're looking at hospitalizations, our indicator for action, we're going to be catching the epidemic very late after it's already spread quite a bit.
I want to bring in the viewers. Thank you so much for those of you who are commenting, and please keep them coming. This is from Heidi. She says, can you please, Dr. Brown, ask Dr. Brown the thoughts on the Omicron XE, which we heard about in the paper yesterday. It was announced from the Department of Health that we do see that variant here, and the transmitting rate. It just seems like we get one new variant and then we get another. So tell us what your thoughts are on XE.
Okay, XE is a variant that is actually a recombination of BA1 and BA2. That is, it has taken part of the genome from BA1 and part of the genome from BA2 and mixed them together. That's what we call recombination. Okay, it does have a transmission advantage of probably about 10-15% over BA2. But it's still early in most of the world. It's being tracked in the UK, it's being tracked in South Africa, but they still have comparatively few cases because they're still at the early stages of the XE epidemic. Remember, these things start very slowly. It actually takes 2 to 3 months for a new variant really to gain purchase, to rise to the levels that it can start that very rapid exponential growth. Okay, so XE is definitely one to watch. It is more transmissible than BA2, so it may, in the long run, have an advantage, but we're not sure at this point. Other things to watch. There are actually two new, if you will, children of BA2 that have shown up in New York recently, and those have about a 25% growth advantage. Okay, you know, they're BA 2.12 and 2.12.1, and they are actually what is now growing to dominance in New York State. So we are seeing these variants continue to evolve, and right now they seem to be largely evolving toward more infectiousness rather than toward more severe illness. And that's a good thing, because it does mean that, you know, for those who've been vaccinated, you will generally not get a severe breakthrough case. If you do get it, you will have comparatively mild illness. But there will still be some people who end up with more severe cases from that. So there are other variants out there to watch.
And I want to bring in this question from Stan. It ties into that. He said, would Dr. Brown be willing to comment on the time frame of each of the waves? Could we say that each wave from initial to sharp decline around 100 to 125 days should be looking at public policy and managing it through that? We do see these waves sharply increase, and then, you know, they sort of, the variant runs out of people to infect, if you will, and then we get the next variant. So what about the time frame of these waves, and can they come back? Could we see Delta come back, or original Omicron come back, or has that sort of burned out and we don't need to worry about it anymore?
But something we do have to worry about, because if, in fact, enough immunity to Omicron builds up because so many people get infected with either BA1 or BA2, so that, you know, you've got 70, 80% of the population now protected against those viruses for the next 3 to 6 months due to infection. Because after infection, you will have protection against those variants. But the problem is you may not have protection against Delta anymore, or not have as good a protection against Delta as you have against those variants. And that's what we saw with Omicron originally. Those who had a Delta infection only got a moderate protective effect against Omicron. And that's why Omicron spread so quickly, because it escaped the immunity that came both from our vaccines and also immunity from previous infections with other variants. And so, yes, they do play out in these waves. And understanding them is challenging because it's really a mix of the past immunity from different variants in the past, the vaccination status within the population, how quickly your protection from vaccine is waning over time. For Omicron, for example, we know that after 6 months, you basically had no protection against infection from 2 doses of vaccine. You basically had to get that third dose to get back, you know, 60, 70% of your protection against infection with Omicron. So yes, there is the possibility that some of these other variants could come back in the future. But right now, it seems like these higher infectivity ones are really kind of running the table and seem to be, you know, I mean, BA2 at this point is incredible. Faster than any other variant, it has taken over the world. It is now estimated to be 94% of all recent sequences in the world. Okay, so it really has come to global dominance in a month and a half, basically. But like you've seen in a lot of Europe, it's on its way down right now. So I agree, we should be looking at that entire wave and thinking about, number one, how do we blunt the leading part of that wave? How do we stop it from growing so quickly? And then also, how do we manage the hospitalizations and other problems that will result in the latter part of that wave?
Well, and I think that leads us really nicely to this slide. Tell us what we're looking at here.
Okay, this is actually a quite interesting slide by a modeler named J.P. Weiland. And what he's showing you, the orange curve here is basically the original Omicron wave. Okay, and you see it's coming down quite quickly. Basically by May, it's pretty much going to be wiped out. It will no longer, you know, be a relevant player in the country. But the green curve shows you what BA2 is doing. And BA2 is on an exponential growth curve right now. And so what we actually see in our cases is the combination of these two curves. And that's the red curve with the red dots around it. The red dots are the actual data points for cases in the United States. And you can see that the red curve, which is the combination of the green and the orange curve, is actually doing a very good job of tracking the cases. And what it's showing is what we've seen in the US recently, that we're starting to see a slow uptick in the number of cases. And that's particularly pronounced in the Northeast, but it's also currently more than half of the country is basically seeing increasing case rates right now, even despite the declines in testing and everything else that we've had. The blue dots on here show taking the cases and multiplying by the percent that CDC says are infected with BA2. And you can see that that is tracking the green curve incredibly well, which means that is the trajectory on which BA2 is currently headed in this country, which means we will be entering a more rapid growth phase in the near future in this country from BA2. And that the slight uptick we're seeing now is more explained by the decrease in the first wave than it is by the rise in the second wave, BA2 wave.
I want to bring in this question from Heidi because you did talk about waning immunity in your last response. And she says, with a lower rate of people getting boosters, will waning immunity be a factor in how infections potentially affect potential hospitalization? Do we have any sense of what our actual immunity is? We talk a lot about people who've gotten 2 shots or more. The state is very proud of the fact that Hawaii is one of the leaders in that regard, that we have some of the highest vaccination rates in the country for those initial 2 doses. Our booster rates are not nearly at that level. People really didn't seem to gravitate toward the booster unless they worked in a very high risk setting or were elderly. What can you tell us about what our actual protection is right now and what that could project in the future if we have these highly infectious variants coming into our community?
It's hard to assess quantitatively because we don't have accurate numbers on exactly who was vaccinated when people get their second dose, how far out they are from their second dose. If we had a better vaccine registry across the state, we actually probably could look at that in much more depth and understand better. But fundamentally, if you are 6 or more months out from your second dose, you have virtually no protection against infection from your vaccine. And in fact, your protection against hospitalization in the latest US study is down to about 60%. Okay. So you have 40% the risk of hospitalization that somebody who's unvaccinated would have with these new variants. Okay. So it's important to realize that if you didn't get boosted, your protection against hospitalization, and you got vaxxed before, say, last October, your protection against hospitalization is down. It's not what it once was. And you really should be thinking about getting that booster. If you are elderly or immunocompromised, then you really, right now, 65 and above or immunocompromised can get a 4th booster. Okay. And those people should be thinking about that, especially if we're entering a new wave now. This is probably the time to be thinking about when you want to get that extra protection from a 4th booster. Because again, that will boost your protection temporarily for another month or 2 against infection, but it will also get your your protection against hospitalization back up much, much higher. So again, I really wish that our healthcare providers here were proactively going after people who have not been boosted and asking them to come in and get their booster. The booster is really important.
Well, and for example, I've been boosted, but I'm under 50. And so I'm not eligible for that 4th booster, though if you looked at the timetable, if I were over 50, I would be eligible. So do you think that eventually they will allow for a 4th booster for the general population, or will that be reserved from what you're seeing to those people who are 50 and above?
My guess of what would happen is that will probably be put off for a while, because I actually expect probably by the fall, they will come up with some vaccines that actually combine different variants. So my guess is they will probably put out what we call a multivalent vaccine that actually contains the spike proteins from Omicron, from Delta, maybe from one of the earlier types, so that it actually gives you better immunity against all of the different variants that are out there. I mean, they are working on that. National Institutes of Health actually has a study where they're looking at different combinations, like a Delta Omicron variant as opposed to a 4th boost with the old vaccines for the Wuhan strain originally. And so, we will have better data on that in the fall, and possibly also new vaccines that may look at that. For those, the primary reason for giving the 4th booster for the elderly and the immunocompromised is basically because their risk of severe illness with a breakthrough infection is much higher. So getting their protection back up is really important. For people under 50, the risk of a breakthrough infection getting more severe is much, much lower. It can still happen, but it's much lower than it is for those, say, above age 60 or so. So it's really important to get the boosters to those who would suffer the most severe illness. That will have the greatest impact on hospitalizations.
When it comes to fighting COVID, we have vaccinations and boosters. We also have other public policy measures like mask mandates. Philadelphia, as you know, recently reinstated their mask mandate. Hawaii, we asked the governor earlier this week. He said that they don't have a plan to do that right now, though they are keeping it in schools. What are your thoughts on adding back the mask mandate? I think from just sort of like a general standpoint, I think it would be hard for a lot of people in the community to swallow. Although, if you go to big box stores, Costco, Target, and the like, you do see people generally wearing masks indoors, but it does seem to be quite a mix. What are your thoughts on the fact that we've dropped the mask mandate and should that come back?
I think it's going to be very difficult to bring back a mask mandate from a political point of view. I think politicians at this point are very averse to it because there is a very loud and vocal group, vehemently opposed to mask mandates. I think the good thing here in Hawaii is that, based on my observations in the community, I'd say probably 50-60% of people are still wearing masks in indoor spaces. And the other 40% generally tend to avoid them. I mean, that's a good thing because I think that's helping to blunt the Omicron wave here. Or I should say the BA2 wave, which is still Omicron, but it's BA2. So I think it would be very difficult to bring back politically. But in the absence of a mask mandate, what becomes really important then is that the public knows what's going on, that they have a clear picture of what's actually happening with the epidemic in the community. And that's the problem I have with Department of Health only reporting on a weekly basis now. The public is not getting that information. The media is not picking up on it very much. Most people are not aware, I would say, at this point, that we've gone from a positivity rate of 2.5 to a positivity rate over 5 at this point in time. That is, we've got a growing epidemic in our community. And actually, if I look at the number of tests that occurred in early March and the number of tests occurring now, with that 5% positivity rate, if I still had the 8,000 cases a day that were being tested in early March, I would be looking at over 450 cases a day right now, not looking at this 164. So again, we are probably underestimating the number of cases by about a factor of 3. So
And
there
to that
actually is much more in the community, and people need to be aware of that so that they can make the choice to wear the mask at this point.
And to that end, we're almost out of time. It goes so fast, but I want to get to these 2 last slides that you shared with us because I think they are so important. And that is this one on transmission. Tell us what we're seeing here.
Okay, what's interesting right now is that CDC has, in my opinion, under political pressure, changed the definition of when it's required to wear a mask. The old definition was based on community transmission. And what they looked at was how many cases per day were occurring in the community. And under those definitions, at the current levels, Hawaii would all be classified as either substantial or high community transmission. So you can see Hawaii is red and orange in this map. Okay, the Big Island is red, the rest of the state is orange. That means it's substantial or high transmission. Under the old guidelines, that really would have called for masking in indoor spaces. Let's look at the next slide. This is the new CDC community definitions, so-called community levels, not community transmission. And they are based much more on where hospitalizations are. Okay, and so under this, most of the United States looks like we're in pretty good shape. We're green everywhere. Hawaii is completely green. And that would tell you don't have to worry. And in fact, under these recommendations, before they would even recommend that a mask mandate or a mask requirement be put back into place, we would have to have over 400 cases per day and either 120 hospitalizations in the last week or 240 people in the hospital. And that is the point at which the CDC guidance would currently call for reinstating mask requirements. But like I mentioned, if we were doing the amount of testing we were doing earlier in March, we'd be over 400 cases per day already. Our hospitals are not filling up, but hospitalizations are a lagging indicator. They take 2 to 3 weeks to develop after the cases really start to go up. And then, there's another almost a 6-week lag before deaths start to kick in. Okay, so it's really important to understand focusing on hospitalization means we allow the epidemic to run rampant for 3 or 4 weeks, for almost a month before we even think about doing anything about it. And to me, that is not a public health message. The public health message is when the cases start to go up, then you notify people and you ask them to start wearing masks.
I want to conclude with something that you mentioned right at the top, and that is something that we hear a lot from everyone, especially those running for office, that we need to learn to live with COVID. In your mind, what does living with COVID actually look like, and how are we doing in that regard right now?
Okay, living with COVID means acknowledging that COVID is in the community, not ignoring it. I mean, too many people have interpreted living with COVID as meaning just ignore it, act like it's not there. But it means that you have to be aware that it's there. You have to have good information about that. And that's why I think the fact that, like I started out saying, it's out of sight, out of mind at this point. Most people are not even aware that the epidemic is growing in Hawaii right now. And how do you make informed choices when you don't have that information? Wastewater surveillance will be coming in the summer. We need them to release some preliminary results right now so that people can start to see that there is, in fact, COVID in the community. So I think that's the first thing. The public actually has to know what's going on. And I don't believe our current surveillance system is doing that for people. Second thing, you have to have the treatments in place. I think most people are still going to have a hard time getting access to the new drugs like Paxlovid in the 5 days between the time you test and the time you need to start. Basically, between symptoms and starting the drugs, you're only got a 5-day window. And I don't believe that our healthcare system is currently set up to do that. If you go to the federal government site about where you can access test and treat, basically they list like 10 CVS stores on Oahu, and that's it. They do not list any of our hospitals as test and treat sites. And, my suspicion is that's because, it's probably going to take a long time basically to get there. First, you've got to schedule your test. Kaiser now requires that you schedule your test ahead of time. Okay, so I think testing is also becoming much more difficult. And so when you've got to get these treatments to people fast, if they can't get quick access to a test and then get to a doctor, they have to see a doctor to get prescribed these new drugs. You're not going to meet that 5-day window, and the new drugs will no longer be effective. So I think, that's another problem we have with our living with COVID. We're not quite ready for that. Testing is becoming less accessible. And again, the ability of people to test and to test rapidly is really critical. And that's one reason I'm really going to encourage people. Right now, if you're insured, you can get 8 tests per month from your healthcare provider per person in your family. And they're required to either provide them to you or reimburse you. Okay? So I would recommend contact your healthcare provider and stock up on tests right now so that you've got them when you need them. Okay? And then finally, the public has to be prepared to start taking up masks. And with these new, much more highly infectious variants, like BA2, XE, which is even more infectious than that, and the new ones in New York, which are even more infectious than that, your old cloth mask and your surgical mask aren't going to cut it. You really have to start using N95 masks. They're out there, they're available. People really should be switching over to those and using those on a regular basis, because these new variants are more infectious, and so you need a better mask protection than what people are using right now. So again, I think we need to be informing the public of these things, promoting N95s in public service announcements, getting information out there so people know what the COVID situation is in the community. And I think we're doing a pretty bad job of that right now.
Well, George White says it right here. Doc Brown dropping truth bombs unabashedly. We always appreciate you coming on here to share all of this information, the slides, the data. If you happen to be watching this or listening to this as a podcast, you can always catch this on YouTube or channel 50, so you can actually see those graphics, of course, on Facebook as well. Dr. Brown, thank you so much for being here. Have a lovely Easter weekend and stay safe. Thanks again.
A pleasure as always. And again, everybody out there, stay safe and be careful over your Easter weekend.
Aloha. Well, we love having Dr. Brown on this show. It's really amazing to hear from him. And one of the takeaways also is just the waning immunity if you have just those 2 shots. He really did make a very strong case for getting that booster. And if you haven't considered it, perhaps it's time to talk to your healthcare provider or head on over to Long's CVS and get that shot, because it does sound like there are a lot of people in our community who did get those initial 2 doses but have kind of slept on the booster, and perhaps it would be a good idea to consider that. Those graphics were very interesting. Again, when this broadcast ends, you can go back and scroll through the video and take a closer look. I know some of them are fairly detailed, but he did a great job of explaining them. He's saying that the positivity rate is obviously higher than what we are seeing reported. Even if you go with the reported number, there has been a substantial increase in just the last few weeks. But of course, there are a number of home tests that are not being counted, and he is very concerned in looking at countries like the UK and France about what they are experiencing and how that can inform what is happening here. He doesn't see the mask mandates coming back just because politically it is probably not feasible for anyone to bring those back at the moment unless things get really bad. Again, our elected officials have said that they are looking at hospitalizations. Dr. Brown countering there that that is a lagging indicator and that we need to take a more holistic picture. He also talked about the XE variant and 2 other Omicron variants that have popped up even as close as New York. And so those could be on the horizon for Hawaii. It is always great to hear from him. Pretty sobering conversation, but one that we need to have because we want to make sure that we're all informed when it comes to living with COVID. And, you know, I really liked how he put that at the top of the show and the end, that living with COVID doesn't necessarily mean pretending that COVID does not exist. On Monday, we will be talking to Dr. Chip Fletcher, who is the interim dean of the School of Ocean and Earth Science and Technology at UH Manoa. We're going to be talking about coastal erosion and climate change. He is a fantastic expert. I've had an opportunity to talk with him a number of times in the past. If you are interested in climate change and what that means for us here in Hawaii, please do join us then. Ryan will be back. And until then, have a great and safe Easter weekend. We'll see you right back here Monday at 10:30 with Dr. Chip Fletcher. Aloha.
This episode of Spotlight Hawaii is brought to you by Long's Drugs.